Good evening, all the students present here. The topic for today is obstetric emergencies, but it is a CCS session. And the speaker that we have here is Associate Professor in Anesthesiology and Critical Care, AIMS Patna. Thank you, sir. So you may start.
Good evening, Neeraj.
Good evening. Good evening.
मैं
Where are you? You are
मैं फातिमा का सिस्टम से ऑन ये किया हूँ.
you are in dark background, I think. Okay.
Oh,
So we are
Fatima,
starting.
congratulations.
Thank you, sir.
Fatima has
Thank you very much,
completed
sir.
management degree.
अरे वाह, चलो. Heartiest congratulations, Fatima.
Thank you,
Very
sir. Thank
nice.
you, sir.
Very nice. चलो ठीक है. So, a very good evening to all of you and all the students, those who are ready to join today's class. I think today class is very, very interesting because what I see that many of you are new in this batch. So like I think Rajan and Pika and then I think Tom is there. So I think it is very interesting. It's a basically a STEM based class in which I will be giving you a STEM and then we will be discussing that how the questions in the real examination in EDIC will be going to get asked. Okay. So as this topic is related entirely to obstetrics critical care, so I will be touching few important aspects that my STEM will start with a case and then after that we'll touch different important aspects of obstetric critical care that like that we will try to judge you on the basis of whether you have any idea about severe preeclampsia, then later on after that the concept of amniotic fluid embolism, and then later on we will take you to therapeutic plasma exchange and then DP mass system, that what is the new technology that is DP mass and how it is better over hemoperfusion for, and because the last resort is definitely a liver transplant, but we will not going to that extent, but we will be closing our session till the difference between that your hemoperfusion as well as DP mass. So I think if you will have any doubt in between the class, you can definitely write on the chat box for any queries related to today's class. Okay. So now the thing is that your the case scenario is, so every case scenario has around, I have kept around 5 vignette. Okay. So the first case scenario starts with a 28-year-old G2P1 and patient that is admitted to labor because she was having a labor and delivery at 28 weeks of gestation. But now she has started complaining of headache as well as blood vision. Okay. Now her BP was 200 by 110 with 2 plus proteinuria on urine analysis, and repeat blood pressure a few hours later is 160 by 110. So the two reading of blood pressures was taken care of, and both the blood pressures were from 200 to range to 160. And meanwhile, the lab values has also come, and the lab value was showing a normal hematocrit and with a normal platelet count and normal liver enzymes level. The vital signs recorded at the time of admission was the blood pressure 180 by 110, heart rate was bit tachycardic 123 by beat per minute. The patient was tachypneic also 25 breaths per minute, and temperature was 34.2 degrees Celsius, and she was maintaining oxygen saturation at 98% on room air. Now, on quick physical examination, the patient, the examiner noticed that no pallor and icterus was there. Although what he noticed that the swelling of a head, hand as well as face was there, and CNS was in CNS system, the typical findings like blood vision, severe headache was there. And on routine examination urine, it was showing more than 300 milligram percent of protein in last 24 hours collection. So 24 hours collection shows this. So the first in the vignette 1, the first question was that because we have a set of 5 questions. So the first question was, how would you define preeclampsia and severe preeclampsia? So you have to you have to be very precise, because when we will discuss all those things in our mock class or in the real exam viva, the question will be like that, and then we will ask the student to answer without seeing anything, without seeing that mobile and all. So he or she has to on the screen, and then he has to answer this. So define preeclampsia and then what is severe preeclampsia, because today is our class, so we'll discuss all those things step by step. And then the simultaneously the next question was that, can you enumerate the 6 appropriate lab investigation that is required to assess the severity of the preeclampsia, whether that preeclampsia is moderate in type or severe in type. How can you label, or how can you know whether there are some important investigation that is attached which judges the severity of preeclampsia, and then how this patient has to be delivered, whether she can delivered expectant or some special care is required for this patient, and then what are the potential causes if the patient land up from preeclampsia to eclampsia. So what could be the probable cause of convulsion in third trimester of pregnancy or puerperium, and then what are the agents that you will not use in the management of severe hypertension, especially in preeclamptic patients. So these are five important sets of questions, and each questions has to be answered. Okay, so if in the real exam, if you have to answer, then you have to answer like that. There are two cardinal features which makes a diagnosis of preeclampsia, because first we have asked about the preeclampsia. So there should be a sustained hypertension. How will you know that the patient is having a sustained hypertension? If the systolic blood pressure is more than 140 and diastolic is more than 90, it is for preeclampsia. Okay, and then what is the status of proteinuria? I think Hassan, can you mute your mic, please? Hassan, please mute your mic. Thank you. So the second point is the proteinuria. What is the level of the protein that is present in 24 hours after urine collection? Whether it is more than 300 milligram protein is there or not. So for defining preeclampsia, these two definition has to be there. And then if the systolic blood pressure from 140 to goes to 160 and diastolic from 90 to goes to 110 on two different occasions, at least 2 hours apart, with proteinuria more than 5 gram. Now it is 5 gram in 24 hours, not less than 300 or not less than 300 milligram. It is up to 5,000 milligram in 24 hours. Oliguria, now the urine output is reducing a bit. It is less than 500 milligram in 24 hours, ml in 24 hours, and then elevated serum creatinine. The patient should show sign of pulmonary edema or cyanosis. The patient will have a persistent headache. The patient will have a visual disturbances, and the patient will have a seizures, some seizures features as well, because in many times the preeclampsia patient, they may present with some of the time convulsion, but not always they will present with convulsion, and the patient will have a typical epigastric or right upper quadrant pain with elevated liver function test. So these may be one of the findings in case of severe preeclampsia. So all those parameters will be normal, and then your lab parameters will be started to deteriorate, and the thrombocytopenia will be there. The patient will may be having a deranged PTINR as well, and the patient will have, at this point of time, the mother may be having a oligohydramnios as well as decreased fetal growth, or the patient present with placental abruptions. So these all are signs which is mimicking or which is making a diagnosis for a severe preeclampsia. So in real exam, you have to tell us 2 hours apart definition, cutoff value of blood pressure, and then these are the classical clinical features for defining a patient for severe preeclampsia. Okay, so this is vignette 1, question number 1. Now coming to the next part, that what are the laboratory investigation that is required for this patient for showing that, with how can you know that the patient is having a severity in the preeclampsia as well. So that is again, yes, many of the times it is mostly associated with the eclampsia are mostly associated with seizures, but few of the patients may present with, in severe stage or is in severe preeclampsia, the patient will may throw a seizure. That has to be there, although the percentage is very less, but it has to be there. Maybe there are cases that the seizures is there in severe preeclampsia, but not in mild, not in moderate. It is in severe preeclampsia. Okay, now coming to the appropriate investigation, that is why this is that is important, is what are the various laboratory investigations which I already discussed. So here the lab investigation will start with your CBC count first. And then you, apart from your CBC, then your blood urea nitrogen, serum creatinine, and then serum urate level. You may be in severe preeclampsia, the patient will, in severity, the patient will show a transaminases, so transaminitis will be there. The deranged in coagulation profile, the patient may be having a thrombocytopenia features. Here many of the time the student forgot to tell this. So this is important one, because in every exam they doesn't able to talk about that blood typing and antibody screening, because at this point of time this is important, because the patient the patient blood grouping and blood timing or antibody screening is always required. And then your 24 hours urine collection of the protein, which you already seen in previous slides, that how the protein from 300 goes to 5,000 milligrams in 24 hours collection. So these are the 4 or 5 sets that you have to think of for labeling the severity. Now coming to the third question, that what are the potential causes of convulsion in third trimester of pregnancy? Now again, there may be the patient will present with